Yeah, God, now I got to start talking, don't I? So, hi, I'm Josh Corsa. I'm a trauma surgeon up at Prov Everett, just up the road here, and Miles wanted me to come kind of chat with you guys about kind of the different things that I do in my life. So, we've got EM here, EM interest group, wilderness interest group. Anyone from surgery here? Eh? I got a weak wave and a yes. Perfect. Anyone from anything else, non-emergency medicine, wilderness, or surgery? Family. Whose family? Excellent, good. You guys, the non-EM folks, are kind of my target audience here. And the reason for that is EM folks know all the cool crap they can do, right? And we've always been told if you want to do cool stuff, you have to go into EM. It's garbage, all right? That's the first thing I want to enforce, is that anyone can do any of this stuff. And on that note, can we get this little thing to go away, or is that, I'm just kidding, nope, we're not going to mess with it, it's fine. So how to do cool stuff with your medical degree. And this camera's going to follow the back of my head, that's awesome. So there's 4 things I kind of do with my life that I talked about before. I work about 12 days a month as a trauma surgeon in Prov Everett, 12-hour days, which means I have a lot of time for other things. And so I'm on the search and rescue team, the helicopter team. I'm in the Army National Guard. I do the SWAT team for Snohomish County, as well as run EMS for San Juan County, like the Orcas Islands. And so I'm just kind of going to give an overview about stuff that you can do with this that you might not have thought about before. And please, God, ask questions. I hate the sound of my voice, so the more you guys ask, the better it's going to be. So, yeah. So everyone know Miles, at least the wilderness folks here? No. Okay, so one of your 4th year now? Okay. Is one of our rescue technicians. And so in Snohomish County, we've got one of the biggest search and rescue agencies on the West Coast, about 300-400 people. We do dogs, we do ATVs, we've got 2 helicopters, about to get a 3rd, and we even do drones now and all sorts of stuff like that. And part of that is a medical component, and there's 2 physicians involved. And we kind of oversee the medical care, both directly by flying out on missions in the helicopter, and then by teaching the EMTs and the first responders and all of that, and as far as the search and rescue team. Anyone know what the difference between like first responder, EMT, and paramedic and all that stuff is? Go for it.
Yeah, first responder, they're just different scopes, right? So
exactly,
first
yeah.
Responders, I'm not exactly sure what the scope is, but then next step up is EMT and then paramedic and stuff like that.
Yeah, so first responders, like your first aid kind of stuff, right? You're able to splint things, do bandages, stuff like that. Then your EMT can do a bit more. It can do like Narcan, epinephrine, some medications like that, oxygen administration. Then paramedics are the ones that can intubate, defibrillate, do about 50 different drugs and things like that. We have all of that kind of under our scope with search and rescue. And so we get to do fun stuff like rescuing people out, and then also being the Uber for the tactical SWAT team as well. We all just kind of stand around on the little upside down umbrella underneath the helicopter and get flown into different meth labs and things outside of Darrington. So there's all sorts of fun stuff you can do. Here's a patient that we're about to load up on the helicopter, all kind of bundled up. And so what kind of stuff can you do with this? So there's ground search and rescue, where you go out on the trails and you look for people that are lost. There's flight, where someone will activate their little beacon, or they'll say, you know, they'll tell someone run to the trail and I've broken my leg and I'm kind of stuck up on the trail, but we can't get to it. So we go in and get lowered down on a hoist to go pick them up. And the involvement on that kind of stuff is as much as you want to be. If you're afraid of flying, that's fine. You can walk in or drive in, or you can just be in the command post. You know, it doesn't always have to be spending days in the wilderness in the blowing snow and all that kind of stuff if you don't want it to be. You can also do medical support for expeditions. All these expeditions like Antarctica, Denali, Everest, and places that are warm, Kilimanjaro, the jungle, stuff like that, need a medical component. And that's part of that is planning. Like, what do you do if someone gets hurt? How are you going to get them out of there? Where are the nearest hospitals? As well as screening people for family medicine beforehand. What pre-existing conditions do you have? What kind of medications do you have? How are you able to go out into the wilderness and do it safely? And that can be for tourism, be research, or adventure. And then you can do medical support for races and competitions, things like ultra marathon. Shoot.
Is medical support for
expeditions? No, you're fine. Yeah,
it's
pizza.
Like sponsored and paid for? Or do you need to provide your own like expenses?
The answer is yes. So one of the guys that's ER physician up in Everett is in charge of arranging the National Geographic expeditions to the Antarctic. So if you want to be the doctor on that, they pay for everything. It's a free 2 or 3 week trip to Antarctica, which is kind of awesome. Some of these other ones that are lower budgets, things like that, you may have to pay some of your way to be able to do that. It kind of varies depending on how much, but if it's a paying more tourist expedition, they'll usually pay your way for that kind of thing. And then another way to do it is a lot of these guide services that go out, a big one is the Grand Canyon. They go out for a week or two on the Grand Canyon. They've got a sat phone and they need someone to be able to call for advice. Like, hey, I've got this guy stung by a bee, what do I do? Same thing you do on most of your airliners when they fly overseas or over the ocean and they can't land for a while. They've got an advice line of physicians that the pilots or the flight attendants can call so they can figure out exactly what to do. And the training part is really important. Anytime you're going to go way out in the middle of nowhere, you have to know what you're doing, kind of be safe about it. Everyone here kind of hiking, outdoorsy folks, assuming that's why you're here. All right. So you're the medical subject matter expert. And the reason I poorly bolded the medical part is we are the geniuses when it comes to medical, but we're probably not the geniuses when it comes to climbing and when it comes to rafting and all that other stuff. Right? And so everyone's going to look to you for medical support. And you've got to be very good at what you do because you're probably not going to have a bunch of books you can flip through and stuff like that. And once you get good at that and you know your medicine, you've got to be good at not getting yourself killed out in the wilderness. It's very important. And the more you know about that, like if you love climbing, the better you are at climbing, the more likely you are to be out on climbing expeditions. The more you know about hypothermia and like cold water scuba diving, things like that, the more you're going to be an asset invited to go on missions like that. Because if you don't know what all this garbage is, you probably shouldn't be going out on the side of a cliff, right? And that's something we run into a lot in search and rescues. We have a lot of very well-meaning medical providers that really want to be involved because they hike 4 times a year. But we really can't put them on the end of a rope, you know, coming out of a helicopter safely and have them do that. So it requires a lot of work and a lot of effort to do that. To that end, there's something called the Diploma of Mountain Medicine. And there's also one for dive medicine, the Diplomate in Dive Medicine. This is kind of an international certification that I recommend if you're interested in this stuff, you kind of look up. There's 2 places that do it. There's the Wilderness Medical Society, which is a national organization, and then there's the University of New Mexico. And you can either do it all in a 3 or 4 week block, or you can do it a week at a time over a couple of years. And there's 4 sessions, right? 2 of them are kind of didactics. They'll go over hypothermia, hyperthermia, managing all of this and, you know, contextualizing how to do it in the field. And then the other 2 is a week of high angle rock rescue in Utah, and then a week of glacier crevasse rescue over in Mount Rainier up in the Bugaboos in British Columbia. And it teaches the medical types that have interest in it, but don't exactly have all the skills yet, how to care for patients in the wilderness, how to be a functioning member of the team, and to not kill yourself. I can't emphasize that last part enough. And so we do cool stuff. We do low angle rescue. We do a bunch of kind of how to avalanches. Someone gets caught in an avalanche, how are you going to dig them out? How are you going to rescue them that way? And then we do, there it goes, more of the high angle stuff. There's a few months ago, we were lowering people off the cliffs for a week. Family medicine guy, not an ER physician. Most of them were surgeons, anesthesiologists, and family medicine folks. So there's a ton of opportunities to do this. And so you learn a lot. You learn to work as a team and kind of how the incident command system works, how you're going to break up the rescue component, because you're already going to know a lot of the medical stuff. But you got to add that other part to it before you can really get out there in the woods. Not to mention some really fun places to go and learn. You usually get to ski every afternoon in the wintertime. Usually get to go play in the rivers or whitewater kayak or whatever in the summer. Oh, that went too quick. So this is from Mount Rainier this year, and you already saw the next slide. One thing if you're going to go out in the wilderness is you need to embrace suffering. You're going to need to learn that it's going to be miserable at times, because things don't usually go wrong on 75-degree sunny days, do they? Not often, right? Things go bad when everything is going bad at once. And you need to be able to function in that kind of environment. And not to scare you or anything, but you need to know kind of what your limits are and be comfortable being a little bit cold, not eating for a day, and be able to do your job in that kind of environment. Because again, you're not going to usually be called upon to do anything until everything is falling apart around you. So this in the space of about 13 hours, went from that to that. Remember those guys that got caught up on Liberty Ridge earlier this summer? We were on the other side that same day. And so it is amazing how quick things can change. And you're kind of stuck. You're like, well, we could go down or we could go up. Both of them are equally dangerous, right? And that's the situation where someone can't see far. They're going to fall in the crevasse. They're going to break their leg. Now what are you doing is whipping at 40 miles an hour and you can barely see anything. And that's the kind of environments that wilderness medicine usually happens in. God, it's really killing me with the memes that thing's there. So when it says, I don't know, I didn't think I'd get this far, right? And that's a huge part of all of this, right? And a good life lesson is planning, right? So much planning goes into every mission, so much training. You don't just grab an ice axe and go on out there, right? And you should have contingencies upon contingencies, just like trying to figure out how this darn computer works, right? Should never just stop at plan A or plan B. And I kind of draw the Army comparison here. We have things called the PACE plan. It's a primary plan, right? What happens if that doesn't work? We go to the alternate plan. That doesn't work, the contingency plan. And what happens when everything doesn't work? You have an emergency plan. And this is good in a lot of things, not just in the wilderness, but think about it, in surgery, in emergency medicine, anything you do, it's good to think ahead. What's going to happen if this fails or the next thing fails after that? But the stakes are significantly higher in the wilderness aspect of it. And they're even higher, again, in the disaster medicine end. So that is basically wilderness medicine and vacation medicine in places you never want to vacation. And the key to this is you're doing more with less. And that is the most fantastic part and the most wonderful part about all of this is you're given a box of stuff or a bag of stuff and you've got to make it work. And how are you going to do that? And how are you going to improvise with what you have? Because you're never going to have all the meds that you need. You're not going to have a nurse there handing you the ET tube when you need to intubate someone. You need to do it all on your own and you need to do it with what you've got. And to that end, in this state especially, we've got what's called the Northwest Healthcare Response Network, which is kind of our overarching disaster management agency for the West Coast. And we've developed something called the Crisis Standards of Care. And what that is when everything goes wrong, what is acceptable? What can you use in place of a chest tube, right? Use ET tubes. Blow up the balloon, they're going to fit in there just fine. What happens when you don't have those? What's the next thing you can use? You're not going to have dialysis machines. You're not going to have ventilators in disasters or out in the wilderness. What happens if you have 2 or 3 patients that need to be bagged at once? You've got to figure out how to triage them, how to make it work, and how to divvy up your resources. And most importantly, being able to accept what you can't control, because you're never going to have enough stuff. You're never going to have enough people. And you need to make your peace with that ahead of time. So clamshell thoracotomy, didn't have any knife blades, but we did have the actual scalpels. You know how the little 10 blade comes in that tiny little package? You probably had it for A&P. So that's what you use. Just pinch it between your fingers and slowly do it, and then take trauma shears across the rib cage to get it open. You do with what you've got. Funny thing about this isn't a disaster. This is outside of Johannesburg in South Africa where I worked for a while. And it's amazing how much of the rest of the world gets by with just a little bit of ingenuity in what they have available. To that end, yeah, go ahead. Thank you for asking questions. I appreciate it.
What's the scope of you as a physician out in the wild compared to a paramedic? Like, what additional things can you do given the, like you're talking about, limited resources? Is there additional things you can do that paramedics can't do out in the wild?
I hope not. What you bring are 2 giant frontal lobes. You bring your knowledge with you. That's all. The paramedics are very good, and the procedures you're going to do in the middle of nowhere are somewhat limited. Right? You're not going to do major surgery on them. You're not going to do a lot. You'll do maybe a crike, maybe a needle decompression for a tension pneumothorax, which the paramedics can do. What you bring is the calm decision-making ability, and you bring the experience and the knowledge, like contextualizing all of that and working through those downstream effects of how you're going to plan through it. That's really the thing that physicians bring that the paramedics don't have. As far as stuff, again, you'll see in a couple slides, we don't bring much with us when we go somewhere. It's minimum amount of stuff. And in case I forget it, we plan for what's called 80%, right? You get to the 80% quickly. And what that means is I want to cover 80% of everything that can go wrong and do it right now. Accepting that about 20% of the time, I'm not going to have the stuff to do what I need. because it's too heavy, it's too much. I can't fill my backpack full of all those, well, what if kind of stuff. I'm not going to bring an AED out in the wilderness with me, accepting that if someone happens to have a sudden cardiac arrest, we may not be able to cardiovert them. But when you add that extra 5 pounds, 6 pounds, and you're humping it for a week, that weight matters. What else can I put with for 5 or 6 pounds? You don't carry a lot of IV fluid, same reason. So you've got to kind of make your peace with never having everything you need. And it's similar for EMS. So I trained in Florida, so I have the dubious distinction of working just about every hurricane in the past 15 years. And we've done a lot of disasters, both in the military and civilian. And so this here is everything, plus one more backpack that we have to care for about 5,000 soldiers and 20 or 30,000 people until more help arrives. And this is kind of what disaster medicine is. When good enough is just good enough. And so this is kind of our shelter / staging area, middle of a rodeo arena in the middle of nowhere. And then these are all prepackaged meals and water. And a lot of what you're doing, especially in disasters, isn't cool. It's not sexy. It's not saving lives second by second. It's foot and mouth by the dozens, if not hundreds of cases. It's cholera, it's infectious disease, it's preventative medicine. All of this stuff is making sure people got clean water, clean food, they're taking care of themselves. I was shocked by the amount of foot and mouth we would see. People wading through water, septic tanks, things like that up to their knees, all the infectious diseases they can get. It's a mini derm residency. It's terrible, but there's a huge need for it and it's fun. I'm not trying to talk you out of it, but if you think you're gonna go down there and save all these lives, seconds matter and all that, by the time the plane lands at the disaster, all that is taken care of. What you're doing is more that family medicine, general medicine kind of thing, setting them up for success. People that don't have their meds, the pharmacy has been blown down, right? You need to get them antihypertensives. You need to get them back to baseline as soon as possible. So I grew up in Cape Hatteras, North Carolina, the eastern part, the quarter-mile long sandbar, 13 miles out in the ocean. Also a giant target for hurricanes. So this is Hurricane Isabel. We got hit again this last year. And so the only road coming out of town is in that top left. And so everything had to be flown in by helicopter. The ferry docks were destroyed. We couldn't even boat anything sizable in there, right? So think about that. You've got a town of now 2,000 people that is just cut off from the world. And you are, most of the time, the only doc or one of 2 or 3 doctors available. And so you bring what you think you need and you get to work. And there's nothing more satisfying than being able to take care of these people when they have literally nothing left to their name, no possessions, nothing, but at least they've got their health. This is just a fun picture of an idiot. So he decided that for some reason he was going to drive on the beach right after a hurricane hit. And well, he lost his truck. So all of this kind of is one big Venn diagram. So I want to talk about the military experience. I just like showing the most America photo I've ever taken. So military medicine, I know this is probably not the most popular topic in Seattle, but I've been doing it now for 21 years, and I love it. The opportunities I have had, both educationally and be able to give back and take care of not just our soldiers, but Iraqis, Afghanis, Syrians, Africans, has been absolutely wonderful. And you don't have to be active duty to do this. 65% of all of our medical assets are in the garters or as part-timers. More importantly, there are 1.1 million people in the US Army. There are less than 150 surgeons right now total. We are in a shortage. Please help us. And the opportunities. So you can be a dive doctor, you can be a flight doctor, you can do regular ground medicine, you can work in a hospital, work in a clinic, you can do special operations. There are all sorts of cool things you can do. You want to take one of the best tropical disease courses in the world, we'll send you to Tulane for free to do it the whole time and pay you salary while you're doing it. And it's something that I have just really has helped me grow as a physician. Again, going back to that, how do I improvise? How can I be better at what I have and not be that surgeon that needs a special little instrument for every freaking little thing? So this was 2:48 Christmas morning this last year coming back from a mission. It's not always the most glamorous thing in the world. It was freezing, it was terrible. And I was stuck with about 54 of my best buddies at the time as well. So what we do, or one of the things that I do, is very far forward medical support. So I go out with certain units that are out in the field for anywhere from 2 weeks to a month, or 2 days to a month. And we're doing this way past any hospital, way past any surgical team, things like that. And we're interacting with the locals. We'll set up shop in a house and we're there. We're a presence. We're looking for bad guys. We're doing that. In Africa, you're talking, you could be as much as 6 hours from medevac, someone to get you out, if the weather's good and if we have a contractor available. You're looking at 3 days before you can get to a hospital. And so it really changes the way you practice medicine. Now it's not just how can I keep them alive for the plane to get there, the helicopter. Ah, crap. How do I keep them alive for days? How do I ration the medications? You know, what is an acceptable blood pressure? What is acceptable bleeding? Things like that. And it really changes your perspective on things. Also really makes you appreciate the finer things in life, like a bed, for instance. And so for a month, this is basically where we slept. And this is 2 ORs and an ER and anesthesia in a box. Well, a few bags in a box. And this is it. This is enough for us to treat and operate and do anything from thoracotomies to major exploratory laparotomies on 2 patients and keep them alive for up to 3 days. And that's the whole kind of point of this talk is medicine, wilderness and military and all that. It's amazing how little crap you need when you really get down to it. And so this is a blown up mosque. This is the OR. This is JT, one of my CRNAs. And this was it. Someone got shot. This was our OR for him. And no, we didn't wear masks. Sometimes sterile gloves, most of the time not. And they did fine. They did fine. Our infection rate is amazingly low. And to that end, you don't have to go out there on your next hike or anything with the world's biggest first aid kit. You don't need to look like Batman with all this crap hanging off your belt. When we went out on a very light and mobile mission, this was it. This was all I took to do surgery and to stop bleeding and keep someone alive. There's 5 instruments in here. There's, anyone know what a robot is? All right. Are those whiteboards?
Yeah.
Sweet.
There's a marker under that screen.
Hot diggity. So, okay, I'm just going to tell you about it. No, it's fine, it's fine. So the robot is basically, it's a catheter you thread. Wow, there's always one. It's really fine. So what it is, it's basically a catheter you fish up the femoral artery. You go up there, you go just below the trifurcation, just below the curve of the aorta, and you blow the balloon up. And it stops all distal blood flow. Bleeding stopped, at least long enough for us to figure out what the heck is going wrong with it. And so we would take it, and God, I hope the people that are listening and recording this aren't going to judge me for this. Take it out of the case and you vacuum pack it in one of the little food sealer kind of things. And that's what we'd use because every ounce, every little bit of space, every square inch is important. And so between all of that, this is what we used. And we did some huge operations with it and saved a ton of lives doing it. And one thing I would encourage you guys to do, learn some dental. I pulled out more teeth with that Gerber on my belt than I ever thought. And I'd never done it before in my life. This was like YouTubing it. So I would encourage you, it is amazing in the wilderness how many people are going to have dental issues. Like how to do dental blocks. Just all of a sudden I chipped a tooth, it is killing me, what can I do? If you've got lidocaine and some knowledge, you can block that, right? Get that pain relief so that they're able to focus on safely getting out of wherever they are, right? It's not hard, but none of us are ever exposed to that kind of stuff. I'd highly encourage if you're going to do this kind of austere medicine to learn about dental stuff. Same token, veterinary stuff, right? Knowing a little bit about that, knowing how to take care of people's dogs and stuff was a huge kind of rapport builder. Not to mention they're just adorable too. So, just another cool picture. And then the non-special operations stuff is pretty fun too, right? So you set up a tent, you go camping for a weekend, and you treat everyone who comes in. On our last training exercise over 3 weeks, we had 463 people come through. That included actively seizing hyperthermic at 108.2, some severe asthmatic attacks, run over by a truck, and this is all just training. This is like stuff we do when we're not going overseas.
Where are you doing this?
This was Mississippi in August. The worst thing possible. So we learned from this, right? So next year's training is Louisiana in June. It's going to be much better. It's going to be great. I'm so excited. But there's a lot, again, you think Army, you think all this trauma and stuff. Most of what we do, again, is primary care, preventative medicine, you know, sewing up lacerations and doing things like that. And most importantly, it's dealing with these guys. This is an old picture, but none of these guys are over 20. And I've got a few more years on you guys, but I joined the Army at 17. And when I look back at what an idiot I was at 17, 18, 19 years old, and what I didn't have was any guidance. And you have the opportunity to be the mentor for these medics, right? And these guys, and inspire them and say, you're smart. You need to go out and do great things and teach them medicine and teach them life. And you're surrounded by them, whether you like it or not. And they're just fantastic people. And speaking of fantastic people, there's a tactical EMS stuff. And it's not just kicking down doors. That's the cool part about it. I'm not going to get it wrong. Not going to get it wrong. I like that sentence I just said. But what we do is we're part of the command staff. So I'm in charge of planning, right? So we go out like that meth lab in Darrington. How are we going to get an ambulance to get us out of there? What's the weather going to be like? Do I have to worry about people getting hot, getting cold, rotating them out, making sure they've got the food they need, they're not in poison ivy, all that kind of run-of-the-mill kind of stuff is a big part of it. And then kicking down doors, it's basic trauma care. You asked what we deliver that the paramedics don't. It's really nothing. Situations like this, I'm plugging holes. The most advanced thing I'll do is a cric. And that's about it. Everything else is just basic first aid, but doing it fast, doing it calmly, and knowing what the next steps need to be. And the key part of this, you're like, I don't like guns. I don't like any of that stuff. That's good. When I recruit for new paramedics for the team, if anyone's, oh, I love to go shooting, you're out the door. I don't want people that are really anxious to go mow down felons. That's not what our job is. Our job is to be comfortable when we're under stress or under fire and to just practice medicine. That's all the job is, right? I don't want people that want to blur the lines in that. No, but okay, there it is. It took a minute. All right. And the biggest part of what we do, just like everything else, is training. Right? Before last year, they'd never seen a doctor on the team. They never had any medical care. And currently, up until next week, the police academy for the state does not teach first aid to any of their cops before they get out. Scary. Some of the individual agencies will do it afterwards, but there isn't a curriculum for first aid. We're starting it next week. But this is where it's important, teaching them how to take care of the public, how to take care of themselves. And that's not just on the SWAT team, that translates to when they're out on patrol as well, right? Who's first on scene? It's rarely the paramedics or the firemen. It's usually the cops, right? The shooting down Westlake about a year-ish ago in the subway or the light rail station. Anyone remember that? 3 people shot.
A month or two, like, all right. Yeah,
Was it that? Ah, time flies. So 1 shot in the head, dead. 1 shot right through the femoral artery. A former Marine police officer went down. They remembered his tourniquet training. Tourniquets on, guy's alive. That dude would have died if they had waited for a paramedic or a firefighter or an EMT to get there. And that kind of stuff matters, and that is where we can really save lives. Isn't necessarily me going and plugging one hole, but teaching all these other people how to do that and how to provide care. And so twice a year, and if you guys are bored and want to do it, I run a tactical EMS class up in Snohomish County. We've got a 4-story fire department building. We throw what are called flashbangs. They're really bright, really loud grenades. We play paintball and we shoot at you and all this other stuff. And you learn how to do that and how to do it under a lot of stress and how to do it quickly and safely. The other part about this, especially if you're the newer medical provider on the team, not everyone's excited about medical training. And this goes for any time you're teaching anyone this. The guide's like, why do I have to know this stuff? The cops are like, why do I have to know this, right? Jim is not thrilled right now, but he's doing it. And that's just it. You've got to make this stuff relatable. Like, why does this matter? And so for this one of our more histrionic SWAT team sergeants, I pulled him aside. I said, you're going to get shot on this next practice run. I gave him some blood capsules to spit out and start coughing. I coached him on how to do it. And it's amazing. When you get it super realistic, people's eyes just get wide. they know it's fake, but they really start panicking. And it's important to get that ahead of time. And once we did that, everyone's like, oh, this really matters. But you got to make it relevant for them. And finally, my personal favorite. So, little bit about me. I quit high school, joined the Army, got out of the Army full-time and went to the National Guard and became a paramedic, a firefighter paramedic. I did that up until I lost my mind and went to med school. And so I got my associates working as a paramedic and then went to med school. So for me, EMS and pre-hospital medicine is kind of the whole reason I went to med school. And it's what I love and what I do. And it is by far the most satisfying and coolest thing that I do. And there's so many options for it. You want to go fly with airlift? There's a job for that. You want to go ride on Medic 1? You want to go out to the San Juan Islands, which is a system I run, which is a super urban rural environment? You can do that too. All sorts of opportunities out there for that. And so what's unique about the San Juans? Anyone been there before? Few people? All right. In the middle of godforsaken nowhere. How long's the ferry ride out there? About an hour, hour and a half, depending on the island. So San Juan has a hospital on it in San Juan Island. It's a whopping 6 beds with a 2-bed ED. Orcas, Shaw, and Lopez have nothing. So when you get hurt on Orcas, Shaw, or Lopez, you have 2 options. You're getting flown off, or you're waiting for the ferry the next day. The other morning, we had to wait 11 hours because there's too much fog for anyone to land. And pretty much after 9, 10 o'clock at night, ferries aren't run until the next morning. So now you've got this extra twist where the paramedics who are not trained in this long-term care have to figure out, well, what the heck am I going to do with this patient? And so now you're sitting at the firehouse, hanging out with this patient on a stretcher, making small talk, waiting for the next transport out. And so it's a whole nother way that no one else, well, very few people in the country do that. It's another niche in EMS that you can find if you're interested in that. A lot of what we do is we treat them and then we bring them to the family medicine clinic the next day on Orcas or Lopez. Like, hey, they don't need an emergent helicopter flight out of here, but they need to be seen. And so a lot of what we do is go out and be proactive. I had a lady this morning that took too many of her fleconides. Pop quiz, anyone know what that is? Class 3 antiarrhythmic? So she took a bunch of those by accident. Turns out you pull her drawer open and she has all the meds she doesn't take anymore mixed in with all the meds that she does take anymore. And she really can't remember what she took 10 minutes ago. And so now we're going to go out there tomorrow and we're going to fix all of her meds. We're going to figure all that out so that it doesn't happen again. And there's a lot of outreach stuff like that that doesn't happen in the urban area. Plus you get to fly in really cool planes too. Or sit around and wait for cool planes to show up. No, we didn't use that one in the back to fly people out. But originally, as of about 20 years ago, it was a plane about that size that was a medical evac. Yeah, it says it all at the end of it. But especially with EMS, there's a lot of good, and I run all the calls I can to remind me of why the heck I'm doing it, because you will go to more meetings than you thought humanly possible. I sat in a 3-hour Board of Commissioners meeting yesterday where people are complaining about the color of the ambulances. That's the beauty of island life in a small town in November when there's no tourists and nothing else going on and the weather's too bad to go outside. But anyways, you've got to coordinate all of this. And this is where you guys learn a lot about coordinated care and just being part of a healthcare system. And this is really step 1 in all of that, is being the medical director for EMS and how you can get the ambulances to work with the hospitals, to work with home health and hospice and all of that. And you've got to make everyone as happy as possible. Priority 1 is to make the patients happy and then make the paramedics and EMTs happy. And you've got to challenge them. Like, we're putting ultrasounds up there. We're giving them pre-hospital antibiotics to administer. These are smart people and they need the ability to do more with it as they go. And most of all, this looks like Halloween. It's not, I promise, it's just training, is teach them the stuff. Again, what you bring to the table is your brains and your experience and your ability to teach them how to do things they may not have done before, to teach them how to do it right and to coach them to get better at it. And not all of your simulation is going to be the most realistic in the world when you do it. But the key is to just get them engaged. Don't kill them with PowerPoint. So one of my favorite things to do, for those, most people don't know, and I try to hide it, I've been the world's darkest cloud. I've been involved in roughly a dozen mass casualty incidents. I was a dude on call for the big shooting in Orlando a few years ago. So disaster medicine and mass casualty is kind of my jam. And it's hard to relate that, right? You can't do that through PowerPoints. So I went on Amazon, bought little craft dolls and stuff like that, little patient conditions, and I gave them green through red, and I gave everyone a stack of 20. I said, all right, ferry just crashed, fix them. Who goes first? And walked away. And so you put them in groups, and they can all reason through it and figure out who's going to do what and all of that. And it's just simple stuff like that. It takes 5 or 10 minutes, but it's so interactive and so much fun for them, and they learn a ton out of it. Because if you put them in that situation and get them in that mindset, they're really going to be able to retain it. So I'm almost done, and then we'll have time for questions, still get you out of here by 7. So the leadership aspect, I can't emphasize this enough. It's going to be your training, right? The things that you do, the knowledge that you give people, whether it's in this wilderness, austere medicine kind of thing, or just in your lives, teaching med students, teaching residents down the road, right? You're going to impact a lot more people doing that than you ever will through your direct patient care. And be the mentor and the leader that you wish you had. We were talking about, oh, you're hiding in the back now. We were talking about this earlier. So much of your job, your career choice in med school is based on the people you interact with. I went into this thinking I was going to be an ER doc for sure. Without a doubt, I come from an ambulance. That's going to be my jam. ER docs are just not welcoming, friendly people. You know, my first year, the trauma surgeons were like, hey, man, come on down and party with us. Go grab some scrubs. Go to OR7. You're going to put in a chest tube. I'm like, holy crap, I'm a first year. And like, they're so engaging, and they just want you to love what they love. And so much of what we do is based on our interactions in first, second, especially third year. Like, and let's face it, surgeons do a god-awful job at selling ourselves, right? You're going to get on rotation like, these guys are a bunch of jerks. They work all the time. I never want to do that. And so much of it is dependent on getting those mentors and hooking up with people that you can relate with, and you can see yourself being them. And eventually, not too far from now, you're going to be those people, right? And it's going to be miserable in intern year. You are not going to want to talk to a med student. You're going to be like, oh my God, just go away. I've got 9 million notes to write, and I just want to die, right? And they tell me I'm supposed to eat right and go work out after work. I'm really just going to go home and have a beer and sleep 6 hours before I do it again. You've got to try and find time as best you can to teach that next generation coming up. To that end, paramedics, EMTs, first responders, they're smarter than you think. Most of the public, I say most, I've worked at Harborview for a while, is smarter than you think. And when you're teaching them, don't talk down to them. They want that knowledge, right? And if you go off on a 15-minute rant about diverticulitis, they're going to love it. They're going to soak that up, and they're going to be better for it. They're going to jot down notes, go, all right, I'll look that up. I'll Wikipedia it later. And so I think that's a big thing as physicians is we try and dumb things down too much or treat them like they're really not the medical professionals that they are. And finally, be present. No one liked the Wizard of Oz because he hid behind a curtain the whole time, right? If you're in charge of these agencies, you're working with them, work with them. The coolest things I do is get to drive around with lights and sirens and a radio. I can't believe they let me do it. Show up on scenes, work with them, go out on these expeditions, go out on these adventures and on these calls. Be there, be someone that they can ping questions off of. Don't be the person that's just writing orders and hiding in the back, doing the administrative part. Because this is the cool stuff. This is about 7 different EMS agencies, a few Green Berets from first group, and some other folks that we got together. And this is our average tactical medic class. And we all learned a ton from it. This is my SWAT team. Some of the coolest guys on earth. Yes, one of them is wearing a Care Bear outfit. Please don't ask. It's the new guy. He screwed up. He had to wear a Care Bear outfit for the week. But these are the people. You're going to find folks that really make this job so much better. And anything you do that way, whether it's guides that you just go out climbing with afterwards when you're not doing the medical thing, or people that you work with, and thank God it blurs out half my face there. It's all about the relationships and how you can get them better and get them able to do their job better. So this is, everyone wants to be a gangster until it's time to do gangster stuff. So it's really cool. We all want to go out and do this. You put the time in and do the gangster stuff, and you're going to get to be able to do the cool stuff that comes with it. Because you don't get to this level unless you've put a ton of time into training on your own time and take the initiative to go out there and do it on your own. And that translates to climbing mountains just as much as it does shooting bad guys. So to that end, I stole this from another slideshow just because I have can bend your ears about it and impart a little bit of wisdom. When you train, make it realistic, right? We don't intubate people on tables, right? We don't intubate them in the OR because that's not where we're going to be finding our patients out in the field. We're going to be finding them under trees. We're going to be finding them most of the time passed out in the bathroom because they bagel down and arrested. So I teach my paramedics, do it on the floor, do it in cars, make it realistic, whatever it is you do. Don't just pencil whip and be like, all right, well, that's good enough. We know how to do the skills, but do you really know how to do it when the pressure hits? And this is just good for medicine in general. The absence of orders attack. And what I mean by that is if no one's around, everyone's looking at you. You've got to do something. Stand there, collect yourself, come up with a plan and do it. Because you're going to be confronted on that when you're running up and you're the first one to a code and you're like, oh God, we need a doctor. Oh, shoot, right? Yeah, look, I've only been in attending a couple of years and I find myself, hey, call the oh boy. You know, I need someone that's attending here that's better at attending than me. It happens to all of us and you got to figure it out, come up with a plan, but most importantly, you have to do something, right? There's an old surgical anachronism, often wrong, never in doubt. And it's true because you have to do something, right? And everyone's going to want you to be that calm voice of reason in the room. You can't go to pieces. If it's stupid and it works, it's not stupid, ladies and gentlemen. It's genius, right? Improvisation and adaptation are the most important things you can do when you're out there. And I've figured out so many new and excitingly terrible ways to do medical procedures and things you can do for that. But if it works, that's what matters. And finally, don't drink the Kool-Aid. You're not as cool as you think you are. We all get really full of ourselves from time to time, and it's good to have an ego check. And you can't go into these environments thinking that you're all that, because we always have more to learn and more that people can teach us. So on that note, if you ever have questions, comments, ugly remarks, please let me know. And then I'll end it with a fun picture from Mount Rainier or St. Helens last year. All right, questions, comments, ugly remarks. Shoot.
So I'm sure you've come across and been in the middle of a lot of traumatic experiences and had, I don't know, just situational trauma showering down on you. How do you handle that?
Oh boy, are we talking about feelings? No, I'm just kidding. What do you mean?
Well, I mean, even just watching someone go through some kind of traumatic accident, like watching, like as a belayer, maybe you watch your climber fall. You yourself are imagining that happening to you in your own body, but you're kind of experiencing in a way the trauma of that fall.
Step one, get a new belayer. So no, it's a good question. It's a multi-part answer. In hospital, things like that. Number one, I'm a good Catholic boy, which means I bury my emotions deep down inside and cover them in alcohol. That is not the healthy way. Just a joke, everyone, I promise. I'll give you an example. We had a 2-year-old run over by a car about 3 weeks ago. She came in with a pressure in the systolic in the 50s, rushed her up to the OR. Her liver was basically split in two. It was a grade 5 liver injury right at the hilum. Worked on it for about 3.5 hours. Ended up, she got coagulopathic. She ended up arresting and dying. There is, in our jobs, there is a certain amount of responsibility that you cannot allow yourself to go to pieces because everyone else is going to pieces. And there has to be someone to stand there and keep their composure. And the psychic stress with that is spectacular. But it's the nature of the job and whatever we do. The nurses, the techs, anesthesia, Micah, everyone's gonna be staring at you. What do you do? And so you've got to be the duck. Everyone know that analogy? Calm on the top, paddling like hell underneath. But you don't see it from the top, right? So it's okay to be screaming into the void on the inside, but you have to keep calm on the outside. And then once you go home from work, you got to figure out how to process that. So relaying it to the thing is, you have to have this artificial air of invincibility. Like, I know what to do. I am that person. That can't happen to me. Because if you start thinking, if you start while you're belaying, you're halfway up a cliff face, my God, what if this happens to me? It's not the right mindset to be in. And if everyone's looking at you and you have got to lower someone down a cliff face, you know, you've got to basically be, I am the person to do this, whether you believe it or not. And later on, again, is when you can process all of it.
Yeah, my question was more referring to like, how do you process?
I'm dodging that part if you hadn't noticed. I don't know. It's evolving. I'll be perfectly honest. I'm working on it, and you always will be. There's no good answer. There's something called critical incident stress debriefing, where everyone gets together and talks about events. I went to one of those, and it nearly wrecked me emotionally. It's not for me. And I think there's no one size fits all. So the Pulse shooting, 49 people died. I did 2 thoracotomies on conscious patients and inflicted the worst pain imaginable on them right before they died. I got to live with that. I don't know how to process it yet. And it's still working through it. And so it's evolving. That situation is going to be, how I deal with this could be a lot different than you guys deal with that, and how you kind of work through that as time goes on. But there's something to be said, so in that instance, they're like, you just go home, take a week off. Well, last thing I want to do is go home and take a week off. Number one, my dog will get really sick of me. The second is, we derive most of our meaning, for better or worse, from helping people. It's kind of why we're here, right? So you go through all this, and there's still patients that need all this care and everything. Like, now go home, you're not caring for anyone for a week. It's probably not the best option. And so for some people, it might be. For me, it's not, And so it's really important to just kind of pay attention to what people's needs are and tailor it to that. I wish I could give you a more specific answer. I really wish I could. It'd be better for me if I could. Like, this is what I do, and it works great.
Is there anything that the military provided you that, in terms of, no? I've heard.
Were you in the military? I got this knowing chuckle there.
I think you already said it. Push it down and get it.
Well, to a point. And I think that, no, in a way, the military provided me the best way to process it all. The first time I went overseas, and if this gets too touchy-feely or too tangential, let me know. I'd be happy to stop talking about it. First time I went overseas, they flew us out, got fuel in Germany, and within 24 hours, the last time I took indirect or mortar fire landing within about 100 feet of me, I was standing in a Burger King in the continental United States. Talk about some whiplash. I absolutely lost it. And one of the things that I recognized after is being able to just talk about it or sit there in silence, like we most of the time did, with the people that experienced it together. And so in the military, especially in our groups, there are like 12 people that we work together all the freaking time, and we have the same, we go through the same crap. Us just sitting together, and even if you're not talking, just like, well, that was fucking terrible. And everyone's just like, yup. A lot of times that's enough. And so when you're in a situation like that, like Orlando, we closed down to just this group of us that had that experience, Residents Against the World. And, those are people you can relate with. And you got to find those people that, again, went through it all and worked through it as a group. And so maybe that's why I surround myself with all these tight groups of people, be it the tactical or the search and rescue and all of that. It's because you draw your strength from one another. And so if one person's having a hard time, again, we're guys, we don't emote well. So a lot of it's just like sitting there and, just being there if they need it, just kind of existing together too. And so in some ways, the military really taught me the power in just that. And it's having close bonds with people with shared experiences. Shoot.
Curious about your experience with wilderness medical direction, and obviously you have paramedics on your team, and so they can use their full scope. But I know a lot of places like Tacoma Mountain Rescue, they have you know, PAs and physicians and paramedics who can't use their scope because they don't have medical direction in wilderness spaces.
And so,
how do you manage that? And how can any advice to help like everybody here who's
so that's a tough one. And the reason I say that is because we have some PAs and physicians and things like that. And they don't fall under our scope. The physicians are licensed, they can do whatever they want. They're gonna have to reckon with me later if they do something wrong. But as far as PAs, NPs, nurses, things like that, you are limited. And it's tough, and it's just having a real conversation. But to that end, after talking with them and kind of vetting them, if you will, I'll let them do up to full paramedic scope of practice. But like I mentioned before, there's little to nothing I bring to the table skills-wise that any physician or PA or anyone else is gonna bring to the wilderness outside of knowledge. You know, our skill set, it kind of peaks by what we have in the environment we're in, and that's usually like an ALS level. And so, I mean, I'm not gonna go out there with like a pocket full of amiodarone and rock and stuff, you know. So it's somewhat self-limiting that way because you don't have the opportunity to do your full scope of things. But having said that, yeah, if we've got like a ophthalmologist or something, it's an eye injury, I'm like, Fred, the hell do I do with this, you know? But it's a conversation that you have to have one-on-one and just be like, you know, you realize you're in this capacity as X and you can't do Y. And it's something I recognize too. I can't do everything that I would like to do. And it's, again, limited by equipment and space and weight and all the other stuff. But it's challenging because people always come in like, I'm so-and-so, I want to do all of this. And like, you'll understand in a couple of years that you can't really do it. But does that make sense? I've yet to do something physician level that my paramedics couldn't have done.
Well, I was thinking more of setting up medical direction for paramedics to be able to use their ALS skills under your direction.
Oh,
like, how did you
go forth. So we've got protocols. Sorry, so I guess I should have clarified that. So EMS operates under two different things. We publish protocols of the things they can do, and then if they run out of the end of that, then they can call us and say, hey, what else can I do? I want to do this, but it's not written down. And so we've got a 300 some odd page protocol book for the county of all the things they can do, and they're trained in it. And so on a good day, they don't have to bug us at all. And that's my goal, is to have them autonomous enough and smart enough to be able to autopilot through it all without us having to get involved. And so I treat medical direction, and this is true on the San Juan, as much more of an advice line. Like, hey, I've got this, I'm concerned about whatever, what do you think? Or I want to do this, is that cool with you? And so a lot of it's really offline, kind of built-in protocols they do. The advantage that we have that regular ground medics don't have is we can do limb reductions for a simple reason that if someone has a shoulder dislocation or hip, we can't get them in the basket to put them in the helicopter. Pre-hospital antibiotics is another one, especially if it's a pack out, you know, give Ancef for open fractures. And so we've got some more permissive protocols for our paramedics that are in the backcountry. And that was a discussion with the county medical director saying, these guys are really good, they're backcountry specific, we want to do this. And so we train them every year on the specialty stuff. So they're allowed to do that too. And so, yeah, my goal is to empower them to do everything I feel they can do. Hopefully, again, we pushing out ultrasound, be pushing out finger thoracostomies, doing a bunch of other advanced level stuff because our guys and gals are really freaking smart and I know they can handle it. So yeah, it's more protocolized than it is having to call because not always to be able to call. Is that a better answer? Shoot.
I have,
Oh, well, hello there, God. It's me, Margaret.
Hi. Hi. I'll turn
Hi.
off my video, maybe. Am I going to be a giant face on the screen?
No,
Oh, no,
it's
just
just
small.
a tiny
Okay, good.
voice in the corner.
Hi.
Are you
I
in your
was
bathroom?
wondering, no, I'm at school.
Oh, okay. Where
I'm
are
in
you?
Alaska.
Oh, wonderful. Where in Alaska?
In Anchorage.
Oh, I was just up there to do their disaster trauma
Oh,
talk.
were
What can I do
you?
for you? Yeah.
Thought I missed you. Well, I'm also a paramedic gone med school crazy.
Oh my
and
God, what were you thinking?
I
I don't know
know.
what that look like there.
I think it's just masochistic tendencies.
Yeah,
Anyway.
that's why I'm Catholic. Yeah, go ahead.
I was just wondering if you could speak a little bit about the legality of you running pre-hospital calls, like with your malpractice insurance. as far as like what you're allowed to do outside of the hospital?
So I've got malpractice insurance through the agencies that I'm the medical director of. And so I've got full license to do all of that. And unique in Washington state is anything I do or my paramedics do, as long as it's within a standard, what another physician would judge reasonable or what a paramedic's protocol is, we can't get sued for it. So I carry extra malpractice insurance out of an abundance of caution, but we're fairly well covered for it. Having said that, it would only be in dire circumstances I'm going to do anything physician level. Most of what I'll do is, again, ALS level stuff, or more importantly, I'm talking or prompting the paramedic through doing it because I don't need to be taking their procedures from them. So it's kind of built in as being a medical director. Yeah, I've got that extra coverage, but I certainly haven't needed it yet.
Do you see that changing at all in like moving more toward the UK style of pre-hospital physicians being able to practice at a physician level in the US?
No, and there's a few drivers behind that. I think most of it is the cost. Physicians don't come cheap, and so putting one on ambulances is going to be tough to justify the cost, in my opinion. Having said that, there are, again, most medical directors will respond out to calls, and I know in New Jersey in particular is a very robust EMS program, and they carry everything from thoracotomy trays and amputation sets and all this other wacky stuff. So I don't know the unique, how well that's translated, but I'm somewhat of a pragmatist. If worst comes to worst, I can amputate someone with a 10 blade and something sharp. But yeah, I mean, if it comes down to if you're doing the right thing for the patient, and especially if you genuinely think they're going to die, it's going to be hard for a lawyer to argue practice that. It's just not going to fit the criteria. But having said that, being an EMS physician is what you make it. If you want to be super involved and you want to go out and do really high level stuff, you're the boss. No one's stopping you as long as you've got the malpractice coverage from that agency. Do it.
Cool. Thank you for the info on that.
Yeah, sure. What do you want to go into?
Yeah, probably an EMS fellowship, but I don't know. We'll see. I just can't imagine getting too far away from my pre-hospital people.
No, and neither can I, and that's why I fought like hell to get back into it.
Yeah.
Well, good luck to you.
Thank you.
All right.
Yeah.
You're up.
I wanted to know if you wanted to share some improvisation or creation that you're super proud of. You're like, you think back and like, wow, I can't believe I did that, or like created this and used this to do this, like something you want to share.
God, the line between really cool improvisation and that was stupid is pretty blurry. Ever know what a Black Hawk helicopter is? Big Army helicopter? Did a thoracotomy in one of those. Desperate times. But it's the simple gee whiz stuff. Like if you've been on the wards, there's this thing, a little staple remover, a little 3-prong staple remover. You can use that to sew stitches left and right. That fits the little curve of a needle just beautifully. I like it because I'm cheap as hell. And so you don't have to burn a whole suture kit for that kind of stuff up on the floor. They're easily available. Use ET tubes as chest tubes. So when I go out on tactical missions, I just carry a couple of 6L ET tubes. So I can crike with it. I can do chest tubes with it. I can intubate. It'll be good enough for the time being. Dialysis catheters work great if you run out of the big central lines for resuscitation catheters. You think it flows 3 liters a minute. You can put it in just so you can take it out. So it's a lot of just more kind of, that's cool. One of the fun ones is, all right, remind me when we're done to show you a video. You know the Foley in the heart trick? Someone gets shot or stabbed in the heart and they're bleeding out. You shove a Foley in there, you blow it up, little bit of tension against it, and plug the hole till you can sew it shut. I've also done that for a gunshot up here before. You thread a Foley through the bullet track and blow it up, and it'll tamponade it until you get access to it. So in terms of things that give me nightmares and literally keep me up at night is gunshots here. because it's nearly impossible to get to the subclavian artery in a jiffy. One way I found out from a case study in 1943 in Bougainville, which is over in like the Marshall Islands or somewhere, in the Pacific campaign. You slice between the first and second ribs, you stick your hand in and you pin the subclavian up against the sternum. And then with the other hand, you're able to do the clavectomy and tie it off. And so if you're interested in all of this, there's a book called Improvised Medicine that is about this thick. It will teach you how to do IVs with coconut milk, which also we did in World War II in Southwest Pacific. It is an awesome book. You can make laryngoscopes out of a wooden dowel and a spoon. You want to talk about the cool stuff. You flip through there and like, this is awesome. Yeah, OR lights out of car batteries and a couple of headlights, all sorts of stuff. And so I'd recommend reading that if you're really interested in it. You had a question. Oh, I thought you were about to raise your hand. Just kidding. Okay. What else we got? Shoot.
So it seems like you've worked in a few circumstances like disaster relief or the Pulse shooting where, there's a societal aspect of that, like, gun control laws or, how we
I was warned this was coming.
And
no, go ahead.
How we manage relief funds. I'm wondering what role have you found as a physician in either advocating for or not advocating for,
all right.
Sidelines?
Let me tell you about the year after the shooting. Pardon my French. Fucking frustrating. I testified in front of Congress. I testified in front of the state legislature. I beat the drum for any freaking person. I went on Dr. Oz, for God's sakes. Everything I could. What changed? Nothing. All these upper middle class white kids got shot at Parkland. What changed? Nothing. If that's not going to convince the Republicans to change stuff, nothing's going to. I don't know what the answer is, right? We can kill them with research. We've got plenty of it. It's not going to change the mind. It's not going to change the NRA and how much money they're giving. That's the sad reality of it. Look, obviously I love shooting guns. Do I need to have all these cool, tactical things I have? No. Does anyone? No, not really. But what we forget and what gets lost in all of this is that comparatively not a lot of people die in mass shootings. What we forget is Seattle's a bad example. It's pretty damn safe here. We forget that in South Central LA or the west side of Orlando, the people that are dying are poor people that have no way out and they're doing the only thing they know how, which is gang violence. They're the ones that are getting killed by the dozens, right? We have mass shootings every day if you look at the aggregate, the number of people that are killed. We're never going to be able to fix all the societal problems. And taking all the guns off the street isn't going to fix it either. They're just going to start stabbing themselves. I'm getting there. Give me a sec. I worked in South Africa for 6 months. They don't have a lot of guns there. So they found bottles and machetes and what are called shambox, which, if you must know, I saw a guy beaten unconscious with a dried rhinoceros penis. It's basically a cane you make out of drying it. And so point being, they use whatever they have. And until we fix that, which isn't necessarily a gun problem, that problem isn't going to go away. And so I wish I had a better answer. God knows if we did, by now I would have told everyone about it.
Can I follow this up with a question?
Sure.
So comparing your experience in military medicine and civilian medicine, do you think there are any huge deficits in the knowledge that people in civilian medicine have about, the mechanism of gun injury, how guns work, safety of gun storage, stuff like that?
We want another hour-long lecture because I give that one all the time. Oh, bullets are sterile. We don't need to give antibiotics. I hear all these ridiculous myths out there. People don't. Quick poll, how many people have shot guns before? Any kind? Wow, you guys are pretty militant compared to my usual audience. Usually it's about 50-50. And if you've never shot a pistol or a rifle before, you're really not going to have an appreciation for the damage that it can do or the power it has. And unless you seek out educating yourself, it's still the third rail of both medicine and politics, right? You're not going to have a lecture anywhere on the physics of bullets and how they tumble through the body and the amount of damage they do. Is that important? Hell yeah, it's important, but no one wants to talk about it. We want to put our heads in the sand. I've been trying for a year now to do an active shooter drill at the San Juan, the high school up there. That won't happen. We don't want to do that. We don't want to. I got the drama club was so excited about like, don't want our kids to go through it. It's that attitude of everyone plunking their heads in the sand and pretending it's not a problem that is what keeps us from advancing forward with this as a society and in healthcare. And so, you know that CDC is banned from using any funding to research gun violence, right? So that's a problem. But again, facts, people don't vote with facts, they vote with emotions. And I don't know how to fix that. But yeah, I think educationally, we need to be much more frank about this is what a bullet does. You know, this is the difference between a rifle round and a pistol round. Shoot.
Do
So
you
to
think
speak.
that there's a, no pun intended.
Sorry. Bad jokes.
There's no, do you think that there's a place for, within family medicine for the physician to have a conversation with their patient about whether or not about their guns, if they have guns, and are they being stored safely, and maybe what they could do to store them?
This would get me run out on a rail in Florida, where they just made it law that you can't ask about that.
Really?
Yeah.
Wow.
America.
Oh my God.
Yes. The same reason you should be counseling people against drunk driving and doing drugs and all of that. And look, you're going to tell kids or tell parents, put covers over your light sockets, turn the panhandles inwards, right? What in God's name is the difference between locking up your guns and doing that? That is just simple not wanting your kid to die. Sorry, I get on a rant and I just got to
I'm just
stop.
curious, like, what tips do you have for starting that conversation with the patient? Because that's definitely something that we potentially could do coming up in January when we're
So
PCP.
don't start it, especially if you're out in like Sultan or North Bend. Don't be like, so you got any guns? So, because that's polarizing, right? As soon as you say that, like, oh God, here we go, right? The people are just going to shut down. What it needs to be is, you know, I'm just going to talk about some safety tips. You know, one of those is if you have any, remember to lock them up. You know, it's very important. And again, you say it. A lot of kids do this. You know, a lot of kids shoot themselves with this. Bring up. Do you know of any cases or have anything like that? But I would just make it more of a if you have it and just put the knowledge out there like non-polarizing way, because too many times like you need to lock guns up. You look like a redneck. You got rifles? I bet you do. You need to lock those, you know. They're just going to shut down. And so I think it's much more of a, you know, just when you're going through all of that safety counseling, I would say, if you have any, this is what you should do. And if you need resources to lock it up, we can get those for you.
And what are some good resources for us to look at as kind of like the gold standard for how to store firearms?
So the CDC has those. I will look up, I've got where have I put my phone? I've got some stuff that I can send you for that.
Real quick, Jenny, we always talk about mixing it in with helmet safety, seatbelt. Like,
Exactly.
You wear a seatbelt, you wear a helmet,
And then
you lock your guns up.
Yeah, you treat it as part of that whole thing. What you don't want to do is make that different than anything else, because at the end of the day, it's all about child safety, right? And it should be just part of that whole group. Yes.
So in WWAMI land,
In where?
in WWAMI land, outside, the way that we have that conversation is, like you were just saying, you know, if this is something that your family does to wear bike helmets, if this is something that applies to you, do you know how to use a gun or is it unsafe? You don't assume anything, you don't ask. You just let your patients or your family or family member of your patient, your the patient, basically make that decision. And it lets them keep the agency.
Whammy land, I like that.
Wyoming, Washington.
Oh, no, oh, I worked at Harborview for a while.
Yeah, you're good.
So you're not from Washington?
I'm from Idaho.
Gotcha, okay. Who else has got questions?
Does anyone want to, is anyone on the Zoom and can ask if there are questions? Like in here.